So good afternoon, everyone. New venue, same bright lights. We can't see any of you. So it's an honor to be sitting here with a good friend, Secretary Kate Walsh. We had the chance to talk in your office, I think the last time we had an extended talk. It was about a year ago, maybe a year and a half ago. You were an experienced veteran running BMC, and I was a brand new hospital president. And you said, yeah, when COVID's starting to die down and I'm thinking about announcing my transition. And I thought, stupidly, that you meant you were going to retire. After all, you've had enormous leadership positions at academic medical centers across Boston, including my own. You've led research, innovation, healthcare delivery, education. So pivoting to health services and healthcare delivery on behalf of the Commonwealth, first, thank you for that. And second, does this feel like a natural evolution for you, or is this something that came out of left field?
Oh, it definitely came out of left field, and I was really planning to retire. Our first grandchild had just been born, and I was thinking, okay, I'm gonna, try to see if I can develop some hobbies or some interests. And when Governor Healy talked to me about this role, I thought, wow, that's a really interesting job for somebody who wants to work really, really hard. But what I have to say is I've been doing the job about 100 days now, and I'm absolutely delighted that I took on this chance, mostly because I am never, ever bored. It is a really interesting role. And I think there's so much opportunity to bring the kind of thinking that and innovation and creativity that this conference represents to the people who need us the most. Our secretariat, as it's called in government, touches between 1 and 3 people across our state every day. And so the opportunity to do that better, to do that at a price point we can all afford as taxpayers, to do that in a way that's safe, humane, and effective, I think it's just too interesting a puzzle to pass up, and it's been really fun so far.
Well, I'll just go back to my comment about the thanks, and the thanks is to you personally, but also I believe it's the first time in my professional career that the Secretary of Health and Human Services has real live on-the-ground experience leading a hospital, and not just one, but as I mentioned, you had a major leadership role at Mass General, then an even larger one at Brigham and Women's Hospital, and then ran BMC, including its not just its hospital, but also its health plan. Can you talk a little bit about how that will inform your approach to being responsible for the healthcare delivery in the Commonwealth?
Well, I think the not so humorous answer is sometimes I feel a little like Patty Hearst, that I'm identifying with my captives, but it's challenging because I can appreciate what healthcare executives are going through to try to guide their organizations and their health systems out of COVID, the challenges around workforce, the opportunities to try to reboot what we were before this, because our industry's taken a hit. The only thing that I think we should all keep in mind is that other sectors of the healthcare service delivery side have probably taken worse hits. Nursing home industry, human service providers, and behavioral health providers. And so we need to recover together, because if the other parts of the industry don't recover, the MGHED will continue to be overflowing every day.
Don't I know it?
Yeah. I thought you might resonate with that.
Yeah, you're absolutely right. So I think workforce and unmet needs is going to be a theme that we'll pick up in several of the other topics I'd like us to address. So, as you know, a key theme of our entire meeting these next several days are on the development of new treatments for cancer, for immunologic diseases, and neurologic diseases. And as you settle now into your new role, 6 months or so now, which of these do you think represents the most important unmet needs, and which are the most important parts of your agenda to either improve or address, and how will you do that?
Yeah, it's kind of picking your poison. I would say that that all of the unmet needs really come down to we all need to deepen our commitment and sharpen our pencils and our workforce and our brains around ensuring that we achieve equitable outcomes for everybody. So whether it's in cancer treatment or pick your immunologic diseases. But for me, particularly in this role in health and human services, the opportunities to relieve suffering in the neuroscience space broadly are probably the biggest. If you think about an aging population at the outset, if you think about the number of people with developmental disabilities, delays on the autism spectrum who are aging, living longer lives, have come through school systems where they've been mainstreamed and are going to expect that to continue for their adult lives. And our systems that state government runs and the private sector runs just aren't up to the challenge. So I think there's a real opportunity broadly in the category of the neurodivergent where we can do better good. And I think we're going to have to because that population is growing.
Yeah, I really agree with that. We've done an excellent job of preventing early death from cardiovascular diseases and increasingly seeing similar successes in cancer, which means our population's getting older, living with those chronic diseases, and neurodegenerative diseases waits for a big sector of that population. So let's talk a little bit about the workforce challenges that particular population poses as we think about delivering health care to an increasing number of patients with neurodegenerative disease in the future. What do you envision the state's role is in rebuilding, if you will, the pipeline and ensuring that we have the staff across the spectrum of healthcare delivery?
Yeah, so I think there's probably three things that we need to do. The first thing is when there are cures available or ways to mitigate the onset of these diseases, we need to pay for the patients we insure because we insure the most vulnerable amongst us. The second thing we need to do is think about places where regulation doesn't make sense. And we certainly saw this during COVID. We were able to break all our own rules. So I keep talking about ways to upskill the workforce and down-regulate the requirements for certain roles. A good example is we have by practice, only hired master's prepared vocational counselors for our DDS clients. These are people with developmental delays. There are some people where you need that kind of capability and workforce adaptations are really challenging. And sometimes you're helping somebody learn how to bag groceries. You probably don't need a master's degree for that. So we need to be flexible about how we approach this challenge because there's a tsunami coming at us. And the third thing is better public policy. Creating ways that families can stay involved in their loved one's care and not having to sort of sever the relationship of a family member so that somebody can, quote, get benefits.
So I think that's really well said, and I think it'll be a recurrent theme as we pivot in a moment to talk about behavioral health and the same sort of workforce needs, but allowing each care provider to work at the top of his or her clinical capabilities and broadening our approach to what is a clinician or our acceptance of what is a clinician, I think is really the only answer moving forward as the need for care will outpace the number of physicians in any one specialty. So you mentioned the MGH emergency department, and as some of the folks today know, that was my old job. I worked in emergency medicine at MGH for 30 years, and I saw firsthand what has recently been reported in JAMA, that the dysregulation in acute psychiatric disease among young people is outpacing that of older people by a large ratio, and the suicide-related symptoms has increased fivefold in children and young adults over that 10-year period. And I would add to that study, which didn't really parse out the impact of COVID, that COVID has triggered a second epidemic, and that is the epidemic of mental health. So as we think about the children, children and young adults, children and adolescents, what do you think about their care needs? How do we need to be thinking about this differently? What does the state have in mind for supporting the care delivery to those particular children and young adults that have special needs?
I think I probably at this point should separate a little bit what the state has in mind and what I've learned in 100 days, because it's probably different. But I think that like any large complicated organization, and state government is just that, we're sort of victimized by the silos that we all try to break down in our organizations. So there are, Department of Children and Family Kids, that have severe and persistent mental illness, and 2 agencies that both end up reporting to me and ultimately to Governor Healy argue about whose kid is it. I mean, that's ridiculous. And throw in the fact that until a child is 21, the local Board of Ed is responsible for their treatment plan and payment for said treatment plan. It's kind of a race to the bottom. And I think that there's lots of good reasons why those policies developed, but they don't meet the need today. And so we need to find a way, and I think in my agency, I think we have a real opportunity to do a better job with adolescents. It's that time of life where psychiatric disease is often revealed for the first time. There were kids presenting younger and sicker, and that's a different set of issues. But so I think we need an answer for adolescents that includes many of the agencies that we're responsible for: Department of Children and Families, Department of Youth Services, just an alphabet soup, Department of Developmental Services, Department of Mental Health, Department of Public Health. We need to think about demand management in that setting. You know, is this, you know, what triggered the event that brought the child, the adolescent, to the emergency room? Is it because they are having an acute psychiatric event, or because their parents kicked them out because they're gender fluid? I mean, and so I think there's lots of things we can do on the demand management side within the agencies. Our roadmap for behavioral health, which creates urgent care capacity for behavioral health challenges, just like we have it for physical health challenges, are the kinds of things we need to do, because we can't have the ED be the final common pathway for everybody. We, the state government, are failing. And right now, that's what's happening.
Thinking about those children and adolescents who are the most dysregulated and in need of inpatient care, the last administration incentivized the creation of more beds. I think your administration will be tasked with helping us figure out how to staff those beds, and with what type of provider. What are your thoughts as you settle into the role on that?
So I think we found that the best way to keep beds staffed, and I might change my mind next year, but loan forgiveness seems to be the best way to do this, because we've created loan forgiveness programs for behavioral health and primary care providers, social workers, advanced practice nurses, psychiatrists, you know, a whole licensed behavioral health workers, that requires them to stay in the organization that sponsors them for 5 years. So we are able to, different than scholarships where people get a degree and then go work for a telehealth company, we're able to sort of keep people local caring for patients. This is inching its way through the legislature. It was in the governor's budget, it made it through the House budget, made it through the Senate budget. We think it'll make it through conference, and we'll be able to get some dollars out on the street to people, which I think will help. But that's just one part of the puzzle. We need to think about ways to staff differently and more creatively. You know, it's since I've been doing this much longer than I care to admit, but it's 7 to 3, 3 to 11, 11 to 7. That's not how Amazon staffs. How do we think differently about how we staff the services we provide for? How do we offer people the flexibility that this generation wants, needs, demands, and will find, and still meet the needs of our patients and our clients in the human service world? I don't have the answer to that, but I think we're going to need different staffing paradigms, and part of it gets back to care teams, gets back to different kinds of workers, gets back to peer counselors, for example, in the mental health space, where we think there's real opportunity to do more.
Let's get back to a point you made earlier about harnessing telehealth. And I'll ask you to reflect on your experience both as a hospital president as well as the secretary. There aren't enough mental health workers in this country to provide the mental health care that's needed. And even in parts of Massachusetts, there are a woeful shortage of care providers. There's a lot of challenge in providing telemedicine outside of an individual state. You must have felt that frustration as a hospital president, as I do, thinking about how to meet the needs of a region rather than a state that's limited by license. What are your thoughts on that, and what would you advise those of us who would advocate for change in that space around reciprocity of licensure and such to do?
Yeah, I mean, I think we're getting there. I think it's the expression, your head's been cut off, you just haven't nodded yet. I mean, I do think reciprocity will happen. I think that a lot of it will require CMS to think differently about it. Part of the challenge are insurers who are trying to understand, who I don't think understand the preparation that goes into a successful telehealth visit, and the preparation that wherever you are, you need to do before you engage with this patient or their family member. And so I think there's a sort of circular argument around rate that I think is slowing down progress, frankly, in acceptance and reciprocity. I have heard from families, particularly from children, that in the simplest construct, they think part of the behavioral health challenges our kids are seeing is a function of the damn screens, and then the remedy for that is for them to talk to a provider on a screen. And so I do think there's something a bit circular about that families have at least reflected to me, like, really, do not make me do another Zoom visit. But and there was a little bit of backlash, I think, but I would say that telehealth is here to stay. I think we're not growing the workforce at the rate that we're going to need to, and it's incumbent upon all of us, state government and regulators, the people in this room who innovate and create new ideas, the people who are caring for patients in bricks and mortar facilities, to figure out how to embrace this technology to expand capability and access in an equitable way. We have to think about this so that people who don't have access, who may have a smartphone but don't have access to a data plan, can avail themselves of this technology for themselves or their families as well.
And I think to add to the group that we need help from, I'll add the legislators at the federal level, because I think we'll need federal legislation to encourage some sort of reciprocity and to support telehealth beyond the 2-year extension we just got as part of the omnibus bill. So a question came in that I think is worth talking about. It describes that there are a large number...
That's code for one I haven't prepped for, so beware.
The question references that there are a small but significant number of patients with very long hospital stays, approaching 100 days or more, because they have no place to be discharged to. This has become more of a problem since the pandemic, as post-acute care, ranging from long-term acute care facilities and rehabs all the way to skilled nursing facilities, have had enormous trouble staffing. And that then leads to some patients having long lengths of stay inside the hospitals, which then backs those patients up in the emergency department that you were referencing earlier. So what are your thoughts about how we could address that collectively as across the Commonwealth?
Yeah, so I think there's real opportunity in our state to think, more broadly, and to use some of the regulatory authority that the state has. The Health Policy Commission made a good example. They spend a lot of time talking about hospital rates and increases in healthcare costs as it relates to the one sector of the healthcare delivery system, which is the acute care side of our business. And I think there's I have this mental image of sort of the hospitals being sort of bent by COVID and the sequelae. The nursing home industry was destroyed, and they are barely recovering. And we are facing an aging population that is the fastest growing demographic, or people over the age of 85. By my math, they have not all been doing yoga and eating tofu. The disease burden is really high. There is, we have got to figure out a solution for this part of our economy. That's why I would vote for neuroscience drugs if we can keep, signs of dementia at bay, or learn to live with it like we live with CHF, I don't know. But I think we've got to figure out a way to handle an aging population, and the nursing home industry is really struggling. Mass Health has tried to build hospital at home programs and tried to extend the capability of, skilled nursing level people living in their home with aids and other assistive devices. I think there's an opportunity there as well. But this is a problem that's going to take a lot of likely reallocation of resources across the continuum of care. Creative thinking about regulation, family involvement, We probably need to have a conversation about palliative care and its role in all of these settings that will create opportunities for all of us to just think more differently about what we'd like at the end of our lives, because it's coming for all of us.
I'll pick up on one thread, and that is home-based care. So it sort of feels like Back to the Future, but our health system has made a major investment in delivering inpatient level of care in the home for a select set of mostly medical diseases, primarily in adults. And of course, care was delivered in the home 200 years ago. Our hospital was founded not because hospitals were the norm back in 1811, but in fact because they weren't the norm. Healthcare was delivered at home, and now here we are moving back towards that for a small but important group of patients, which would then free up capacity in the bricks and mortar hospitals. And if we can get to our goal of a significant number of patients being cared for in the home with inpatient diseases, what had been bricks and mortar inpatient diseases, it's like building a small community hospital without having to lay a brick. And it'll be interesting to see how that plays out and whether there'll be support legislatively at the federal level to reimburse for it. So let's pivot, because you brought up neurodegenerative disease several times, and you just mentioned it again. And of course, we all are aware that recently CMS announced that it would permit drugs that slow progression of Alzheimer's dementia in patients to be covered by Medicare Part B, provided that the care providers enroll those patients in a registry so we can learn from the experience. So first, what is your take on this approach? And second, do you see this as consistent with past practices of CMS, or perhaps a softening of how new drugs are approached and approved?
You know, yeah, I mean, I was curious why Part B, why not Part D? I think it reflects the fact that many of the people who can potentially benefit from these medicines are already in a congregate or institutional setting. Not all, obviously. I think it is a way for CMS to put us at risk for performance. Like, is this approach actually going to bring down the overall cost of care for this group of patients? Because I think that's what's coming next. I can't imagine that they would run it through this mechanism without some ability to try to manage that. But I think for conferences like this, and for cities like Boston, or for states like Massachusetts, the price point of innovation is something we're just going to have to grapple with. And Mass Health, the Medicaid program that I'm responsible for now in this role, has gotten legislative authority to work with pharmaceutical companies to pay for very expensive medications on an at-risk basis, so that if that treatment fails, the state recoups, I think it's 80% of their costs after 5 years. That's sort of the general framework, and each case is negotiated individually. We've done it once. I think we're going to do it twice. But I think that we, the state, have to be a whole lot more nimble and a whole lot smarter about how to think about these really complicated questions. And it brings me back to the regulatory framework that we sit in. And when we think about, the state has benefited enormously from innovation, and how do we bring that into mainstream practice in an equitable way that we all want, without sort of killing the golden goose? And if anyone has an answer to that, see me after class, because I mean, that's what we're wrestling with here. And I think that's why, I'm really happy to be here today, and I know the governor was here earlier, because this is, she's articulated 3 themes: affordability, competitiveness, and equity, and this conference is right in the sweet spot of all of those.
So I'm acutely aware of the clock that's ticking down in front of us here. We're inside of a minute. We won't get to every question that showed up on my tablet here, although you did address tangentially most of them. Maybe you can tell the group in the last 40 seconds here, what do you miss the most about your old job?
Oh, the people I work with. It was just really fun. I'd been at Boston Medical Center for 13 years, so it definitely felt like family. Maybe the bloom is not off the rose yet, and we've all stood in line at the DMV, but I have to say I have been really impressed since I've been in government, particularly with the caliber of young people. You know, you're not doing this for the glory. These are hard jobs, and you're not doing it for the pay. But I have been so impressed with these young people who, like, you know, ride their bikes to work after dropping their kids off at daycare or drive biodiesel fuel cars. I mean, they want to change the world. And I'm just really proud and humbled to be part of it.
Well, thank you again, Secretary, for your service. We are all so appreciative.